So here's a 2-year-old international referral. Now we get many international referrals for congenital heart surgery. This is what the echo looked like by TEE in the operating room. Here's the right atrium, here's the right ventricle, here's the right ventricular outflow tract, here's a large membranous ventricular septal defect. When we look at the color, it's very laminar across the VSD, but where's the aliasing? It's aliasing when it gets over here to the right ventricle. If we go back to the 2D, you can see very prominent muscle here that actually when the VSD is emptying into the right heart, it's becoming obstructed as it tries to pass between these sort of hypertrophied muscle bundles down to the pulmonary artery. And in the 4-chamber view, we can see the big VSD here, but when we look at color, we see laminar flow across the VSD, but very alias flow in the mid portion of the right ventricle with those hypertrophied muscle bundles. And there was a gradient of about 40 millimeters of mercury across that, so significant obstruction within the right heart. So this is a double-chambered right ventricle where you have a low-pressure proximal chamber, a high-pressure proximal chamber, a low-pressure distal chamber, and the VSD is trying to come across these obstructed muscle bundles into the right ventricular outflow tract. This results in obstruction. There's a proximal, like we said, high-pressure chamber, a distal low-pressure chamber. Most patients with a double-chambered right ventricle have a VSD, but this may develop without a VSD, and it may develop after closure of a VSD, but these muscle bundles need to be resected in addition to closure of the VSD. So again, I think this is a good